As an oncologist, the principal challenge that we face with this disease is there really is no effective screening. As a result, women often present with more advanced disease than we would like to see. As with many other cancers, the earlier the stage when the disease presents, the more likely we are to cure it. But with ovarian cancer, the most frequent stage is stage 3, which has a small cure rate, but nowhere near as large as stage 1 or 2, because they present with symptoms. We don't have anything like a mammogram, which is used for breast cancer, of course, or a PSA, which we use for prostate cancer. There simply is no good screening. We know from a number of epidemiologic studies that overall survival for Black women versus non-Hispanic white women is inferior. Survival rates tend to range between 29 to 31% for Black women compared to 40 to 42% for white women. And those are studies from the first decade of this century. But to do epidemiologic studies, you have to wait a period of time. So even when you adjust for the stage of presentation, survival is inferior. And that's the principal disparity. When someone gets cancer, they want to survive. They want effective therapy. And we aren't doing as well with Black women as with non-Hispanic white women. I think there's no one simple answer. There are likely multiple factors that contribute to this disparity. There are patient factors. Differences in education can exist, and then patient literacy that may result in them not presenting as early in their disease. There are factors from the clinicians that unfortunately there can be implicit bias that even the physician may not recognize that he or she has this, and that can lead to differing levels of care to different racial and ethnic groups. There are healthcare system factors. Despite the Affordable Care Act, there are still some women who have minimal or no health insurance coverage. This not only can lead to difficulty accessing care when they're diagnosed, but also may mean that a number of comorbidities, be it cardiovascular disease, be it diabetes, that they present with when diagnosis have not been managed. And when you have, say, cardiac disease that has not been managed for a prolonged period of time, you are more likely to have complications and a poorer outcome with therapy. Certainly, while factors such as access to healthcare insurance cut across all racial groups, women with little or minimal insurance coverage are more likely to come from underrepresented ethnic and racial groups. And then there's finally just a sociocultural context that has to be considered. My company works with a lot of Medicaid plans, and we struggle with a lot of structural elements, food insecurities during therapy, transportation simply to get to appointments. And again, this cuts across all racial and ethnic groups, but women from underrepresented ethnic and racial groups are more likely to have these elements. So multiple factors that contribute to these disparities we see in outcome. There are some some ovarian cancer patients who carry a gene. They have a marked family history of breast cancer. They can be screened for what are called BRCA mutations, which increase the risk of breast cancer, but also increase the risk of ovarian cancer. if they are carrying that BRCA mutation, they have a couple of options. One is we can try to screen these patients. It's usually done with pelvic ultrasound and a blood test called CA-125. These have not been proven to be effective. In fact, they've been proven to be ineffective in the general population. That being said, it's the best we have, and the thinking is that in a high-risk population, such as those carrying these BRCA mutations, they might be useful. Additionally, women with these mutations who are past childbearing age can even consider prophylactic removal of the ovaries. The other thing they can do is to be aware of the symptoms of ovarian cancer, and these are non-specific symptoms, but things such as the abdominal bloating, abdominal girth can actually increase, feeling very full quite quickly after eating, discomfort in the pelvic region or low back pain, change in bowel or bladder habits. All of these, while, as I said, very nonspecific and can mean multiple other things as well, but should prompt someone to seek medical attention. Finally, if they are diagnosed with ovarian cancer, they've got to advocate for themselves and push for referral to a gynecologic oncologist who is a specialist in ovarian cancer. And that's absolutely critical. These people should be treated by the specialists who deal with this disease on a regular basis. Two things. First of all, pay attention to that family history. If there is a family history with multiple members, multiple women in the family developing breast cancer or ovarian cancer, you've got to think about the possibility of a genetic etiology and perform genetic testing. And a second is to be very aware of these symptoms. Again, very nonspecific. But if a woman presents with abdominal bloating, with feeling full very quickly after eating, back or pelvic discomfort, pursue an evaluation of it at that point. Very possibly, in fact, more often than not, it is not ovarian cancer. But if you're going to find those who do, you have to pursue an evaluation of those symptoms with a pelvic ultrasound or CT scan.